afternoon and greetings to all. Respected teachers, seniors, colleagues, and friends. It is honor to stand in front of this august gathering today. With folded hands, we, the organizing team of this Pathshala, thank and welcome you all for registering and attending this Pathshala on nailing an infection under the aegis of Indian Orthopedic Association, Maharashtra Orthopedic Association, and Aurangabad Orthopedic Association. I am indeed grateful to each one of you here. A unique conceptual idea by our dynamic president of MOA, Dr. Gadegone sir, with course director Dr. Agashi sir, with studded star faculty coming from all corners of Maharashtra who have traveled all this weekend to enlighten us. Learning is an unending process, and the numbers of registration and attendance itself is how eager all of us are here to learn and seek knowledge. It is indeed my privilege to introduce you all to our esteemed faculty. Dr. Gadegone sir, who happens to be the president of Maharashtra Orthopedic Association, is known to each and every one of us over here. May I request Dr. Gade sir to please present a small rose to Gadegone sir. Thank you, sir. Gade Gone sir is a perfectionist in his game of trauma. He is known to every orthopod in central India. A professor HUD at Chandrapur Medical College, past president of NAILS, present president of Maharashtra Orthopedic Association, past president of Vidya Orthopedic Association. He is a humble man, down to earth, and is always eager to impart his knowledge to teach us tips and tricks in complicated trauma. Thank you, sir. Thank you for being with us. Dr. Agashe, sir, I guess there's hardly anyone out over here who doesn't know this man. We have been hearing him since last 20 years related to infection only since our residency days in Mumbai. Thank you, sir, for traveling all the way from US. He had been just 3 days ago. He was in US, and for all he had been flying all this way, in spite of jet lag and his commitments, he has stood to his commitment and traveled for us over here. Thank you, sir. May I request Dr. Linga, sir, to please welcome Dr. Agashi, sir. Thank you, sir. For those who do not know, Dr. Agashi, sir, had been awarded the Golden Jubilee Oration at IOCON 2009. He is also a chairperson of Trauma Subcommittee of Indian Orthopedic Association 2019 and 20, an advisor to Infection Subcommittee of Indian Orthopedic Association 2021, and of course a past president of Bombay Orthopedic Society. People like Agashi sir are the stars and they add feather to the society we come from. Thank you, sir. Thank you for being with us today. Dr. Gawale sir, we are expecting him anytime. For Dr. Sangeet Gawale, all of you know, is an immediate past president of Bombay Orthopedic Society. He had been our teacher, our HOD and unit head over there. Those who do not know, he is an astute teacher, settle for anything short of perfect. A perfectionist, we call him, and we used to be very scared of him once day. Once he is here, I'll further take the liberty to introduce him. Dr. R.M. Chandak sir, thank you for being with us today. May I invite Dr. Dhule sir, who is Secretary Aurangabad Orthopedic Association, to please welcome Dr. Chandak sir. It was for the first time, sir. Shinde sir, could you please welcome Gawade sir? Welcome, Sangeet sir. Thank you. For the first time in India, remote irrigation aspirator was being used by Dr. Chandak sir. He has published books on pre-operative planning of instruments. Also, he has published a handbook of stages of fracture healing for the beginners, youngsters, and students. He has presented various papers in international and national conferences. An astute teacher who has also designed a patellar suture needle with lot of interest in hydrodebridement. His expertise in complicated trauma, and we all know that we have to one in the morning. If at all we have to see him in his leisure time in the OPD. Thank you, sir. Thank you for traveling all the way out over here. Dr. Aditya Menon, who also happens to come from Mumbai, is also a star faculty with us. He has traveled all the way with Agashi sir, and he is working with Agashi sir over there. Presently, he is honorary secretary of infection section of Asia Pacific Orthopedic Association and had been doing his fellowship in bone, joint, and soft tissue infections. Presently, he is stationed at PD Hinduja Hospital and has been a faculty at international and national and regional conferences. Had also been publications as has his publications in trauma, orthoplasty, and osteoarticular infections. We have just seen a glimpse in the morning. Welcome, Dr. Aditya sir. May I please ask Dr. Gade sir? He's not there. Dr. Shinde sir, please. Please welcome Dr. Aditya Menon. Dr. Sunil Kulkarni sir. Uh, those all of us had been to TraumaCon. He's a very familiar person. All of the best part of Dr. Sunil Kulkarni sir, I like is very approachable. Thank you, sir. Thank you for traveling all the while over here. A teacher who had been at Swasti Yog Pratishthan, and they have been practicing orthopedics since last 30 years out over there. Those who are indulged into trauma and who want to study the notions and the nicks and tips, past president of NAILS, and it also had been with he is associated with TraumaCon since the very first conference. He is one of the leaders and pioneers in starting that. Dr. Sunil Kulkarni sir, may I please invite Dr. Santpure sir. Please welcome Dr. Kulkarni sir. Sir, President Trauma Society of India, NAILS, AO Trauma Council member. He has done all his AO courses as a faculty as well. He has organized many trauma meeting and faculties. Has been a fellow, has been AO fellowship. She's yet to come with us over here. We'll be happy to have her with us in the evening because her session starts in the evening today. She's a consultant division of infectious diseases and is head of fellowship infectious diseases at National Board of Examinations. She's presently working at PD Hinduja Hospital. She's also co-author of a textbook on HIV medicine. She's a co-author of ICMR National Treatment Guidelines for Antimicrobial Uses and a member of Scientific Steering Committee for the Indian COVID Guidelines Group. Uh, on behalf of AOA, MOA, I extend a warm welcome to all the faculties over here. Thank you, gentlemen. The most dynamic amongst all the respected esteemed members sitting here, Dr. N.J. Karne sir, who is also Secretary of Maharashtra Orthopedic Association, has traveled in the morning, and we are lucky to have him with us today here because otherwise you are supposed to attend a meeting tomorrow at Delhi, but we are happy and lucky to have him with us today evening. Dr. N.J. Karne sir had been practicing at Pune over 25 years at Hadap sir, and those in POS and Western Maharashtra are familiar with this figure. One of the most dynamic person who is involved with Pune Orthopedic Society is the president of Pune Orthopedic Society, secretary of Maharashtra Orthopedic Association, and we see him and look up to him to scale and bring more laurels and honors to Maharashtra Orthopedic Association. Thank you, sir. May I please request Dr. Abdullah? Once again, on behalf of the entire organizing team, I extend a warm welcome to all of you over here. We are lagging by almost 30 minutes and we'll try to make up the time. May I please request, we'll start with the sessions immediately. I'll request Dr. Abdullah to come over here and take over the session.
Thank you very much, Dr. Sarang sir. Myself, Dr. Abdullah. I welcome you all in our next session of advanced nailing. Intramedullary nailing is a very frequently done surgery in our day-to-day practice. So let's start our lecture. But before doing nailing, consent is something which we take, and there many things are important. So I request Dr. NJ Karne sir to please tell us what is an ideal consent.
Good afternoon, friends. First of all, I thank Aurangabad Orthopedic Association and the IOA and MOA for giving me opportunity to have an interaction with our august audience like you. Uh, well, every lecture has to start with the consent, and every procedure has to start with the consent. So this is a little bit off the track topic, but it is very important for all of us in our day-to-day life. It is a really test for audience as well as for the speaker to start the lecture immediately post lunch session. So I hope that I'll be keeping you awake. Well, one cannot see ahead without looking back at the past. We are still in search of what should be the perfect consent. What we should see from what we can derive is in previous judgments, the doctor was held guilty, and that also for the lacking in the consent. Rather, consent is the most important part for which more than 50% of the cases have gone against the doctor in spite of the excellent medical treatment in the either a consumer court or in the other courts. First of all, we will see what is medical negligence. It's the wrongful actions or the omissions of professionals in the field of medicine in pursuit of their profession while dealing with patients. Means whatever you are doing while giving the treatment to the patient, if there is anything which is wrongful action or even lack of the action, that is medical negligence. All of us are masters in orthopedics. We attend so many conferences, get all the knowledge in the science of orthopedics. What is required is a basic knowledge of how judicial forums they deal with the medical legal cases relating to the medical negligence, and that is also has become absolutely necessary for the doctors because every day we are finding one or two judgments all over India which are going against the doctors now. The need for such knowledge is more now than before in light of more importance being placed by judicial forum on the value of human life and suffering. What judiciary wants, actually, once upon a time, judiciary was almost in favor of doctors, but last 4 or 5 years, we are seeing the trend is changing now. But what they see, they also claim that while seeking to identify wrongdoers and wrongdoing in the case of medical negligence, they actually aim at striking a careful balance between autonomy of the doctor to make judgments, but the rights of the patient to be dealt with fairly. They expect only minimum standard below which the patient cannot be dealt with. Judicial forums have also signaled an increased need of the doctors to engage with the patient during treatment, especially when their line of treatment is contested and chosen treatment has serious side effects when alternative treatment they do exist. So alternative treatment is also important while telling to the patient. In the process of judgment, the judicial forum tend to give sufficient leeway to doctors as well as they do recognize that human body is complex, the medical science is not perfect. There is inherent subjectivity of the process, and they, some judges also accept that there can be error of judgment while doing the treatment, and as well as there is the they give importance to the autonomy of the doctors. But the law doesn't prescribe the limits of the high standard that can be adopted. We don't know what is the really standard. But what is important, which we emphasize again and again, is impeccable documentation may be lack, and second thing is the flawless consent. These are the two things which are most important, which are not taught in our curriculum, not given in any textbook, and which decide the whole life of the doctor. So what is consent? Consent is important to protect a medical practitioner from liability for harm to the patient arising out of a procedure. Consent occurs when one person voluntarily agrees to proposal or desires of another. There are different types of consents. We won't go into details of all those things. What we'll see is that what is important for us is informed consent. Informed consent is before the patient can give binding consent, a doctor must explain the significant risk of a procedure or medication, which might change the patient's mind about whether to proceed or not to for that treatment. If the doctor does not explain any risk that subsequently occurs, then it is considered as a negligent, because you are telling him about 7 or 8 complications can occur, but if the complication, if you have mentioned in the consent and not mentioned in the consent, if that complication occurs, the case has gone against the doctor because you have not mentioned that particular complication in the consent, which is the rarest of rare complication, but still that should be mentioned in the consent. So after giving all available information, we should allow the patient to decide whether they are ready to take the risk involved in the procedure. The consent which is taken just few hours before or 1 hour or 2 hours before the procedure is not accepted anymore now. That if it is a procedure which is a scheduled procedure, then we have to be at least 1 to 2 days before that. Let the patient think over that, and then you can take consent again half an hour before that. Okay, I'm ready with the procedure, and it has to be in the patient's mother tongue or comprehensible to him, means in his own language. Now time has come to have a 3 or 4 pages consent rather than short one, which were routine in the past. Orthopedic surgeons do routinely take informed consent prior to surgery, but they don't give much importance. The main surgeon never sees what consent has been taken. This is taken either by the office people or by the assistants because they are busy with other work. And in most of the places, there is a blanket printed form with the fill in the blanks. Now, one of the cases gone against only for this purpose, that you have taken a signature on the printed format, okay, which was approved by the local organization, but still that is not acceptable. Then signature on the blank paper. Rather, if you take a signature on blank paper and if you found out it is a criminal negligence, actually it is a crime. So that was a practice in our initial phase. I am 36 years in practice now. Initially, we were taking the apart from the 2 or 3 lines of the consent, we were taking one signature on the blank paper, okay, to adjust later on. But now the patient knows this is a serious offense. Then you have to have witness on that, as well as you should have a patient signature. One of the case has gone against the doctor just because the patient was in ICU, terminal patient, a 74-year-old lady. She died. Relative sued for the medical negligence, but nothing was found in the medical negligence. But only because the consent of that lady was not taken, the case went against them. After this, that particular case, I started taking consent of every patient, because what we were thinking before that, that patient is not in a mental or a physical state to give the consent, and so we are taking the consent of the close relative or the blood relative. But after that case, I started taking consent of the patient also. And as I said, just before taking to surgery, we have to take, but at the same time, it has to be given 1 or 2 days prior to that. Then about explanation. Now, rather sometimes, especially for a spine surgery, we say that we have to spend more time with the explaining the patient rather than doing the surgery. But that is necessary because there are certain areas in orthopedics where there are high chances of medical legal litigation. One is the spine, second is the replacement, and third comes the arthroscopy. Then this is legally inadequate consent. This is again a dilemma. What is really inadequate consent? That is a problem right now. That's why we are working on that. Another part is that overwriting or adding later on that consent without having additional approving signature, again, it is a crime. Rather, if that consent is seen by the judge, immediately the case will go against you, because that means you are, it is a immediately prima facie evidence that you are making some changes in whatever was done in the previous one. So whenever you want to make any changes later on, see that you take a signature of the persons who had already signed there on that. Now, what is legal adequacy? Generally, a state decides the required standard of the informed format, but it's not in our country. Now, here they say this is theoretical, that there is acceptable subjective standard, a personal patient, a reasonable patient standard, and the reasonable physician standard. Subjective standard is what would this patient need to know and understand to make the informed decision. Reasonable patient standard is what would the average patient need to know to be an informed participant in decision, and reasonable physician standard is what would a typical physician say about the procedure. That those things should be at least that in the consent. Now there are certain exceptions. We won't go much in detail in that. If the patient incapacitated or in life-threatening emergencies, or sometimes these are again all technical issues. Voluntary waived consent also can be considered, but these are legal parts. Now, what is important that what we have seen, what is the importance of the consent and what the judiciary wants in the consent. Now, we'll see what are the formats of a given consent. First of all, there should be name of the hospital with logo. If a singly owned hospital, name of the doctor with MCI recognized degree. Remember, in the consent, you should write MCI recognized degree, not the other degree. Then, better to have a local authority registration number of the hospital also, because these days a hospital is also taken as a party to the negligence, and that's why now we are saying don't take only the indemnity of the doctor, but take the indemnity of the hospital also. These two indemnities are totally different. You can be sued for as a doctor as well as your hospital also can be sued. Then patient's details, basic details, all. But apart from that, the identification mark and some ID proof of the patient is required, and hospital registration number, as I said. Then, and patient's number, every patient should have his own hospital registration number. That is generally not in periphery. That the case papers are not kept properly, the numbers are not given properly. It is not only for now income tax purpose. It is for your medical legal purpose also. Now, in the format of consent, the name of the operation, side of the limb, all these things we take. Indication for the procedure or diagnosis. Procedure in short. Sometimes if the patient is too much, we should rather, these days when the patient enters the OPD, what we see first, where this patient is going to land up with some problem rather than what is the diagnosis. And if I'm practicing in Pune and Sadashipet is very close to me, so we have to see all these things with that. And then we decide how we have to change the consent. If the patient comes from periphery, it's something different. So whether to write a procedure there or not, it depends upon the patient in front of you. So first you analyze the patient from that point of view, what is his nuisance value. Short-term nuisance as well as long-term nuisance. Short-term is like a violence, bills and all those in short-term, and long-term is a litigation. The name of the primary surgeon is qualified assistants and their degrees. If it is Ayush, you mention that is Ayush. Ayush is legally acceptable. Ayush is not acceptable by MMC. MMC is a different part. Law is a different part. By law, there are MS orthopedic Ayush also who can operate. So you can take them as an assistant from the law point of view. Then better to write registration number. Now this is again a big issue now these days. Whether you are taking registration in one state and now practicing another state, that is still a dilemma. And for visiting doctors, there has to be a footnote if somebody else is operating, that please be aware that a surgeon other than the consultant, but with the adequate training and supervision, may perform your operation. Because if it is found later on that I have not operated and you have not mentioned the consent, the case will go against you. Now you have to mention all the alternative procedures, the names, which are whatever is available, including there is a non-operative management also. Explain the pros and the cons of all the procedures in short. You can mention, if I want to regain as much physical activity as possible, some of the above alternatives are not appropriate. That all these words should come in the consent. And I have discussed all possibilities with my treating doctor. These are as far as those disclaimers are concerned. Now, as far as implants are concerned, you should explain everything to the patient about implants. What are the implants available in your area? They may be available at Delhi, maybe abroad, but what is available in your area? Then what are the advantages and disadvantages of every implant? Right from, you can say, for fracture fixation, whether it's Indian or imported one, you are going to use the stainless steel or titanium one, because it can happen later on that he gets the knowledge, because these days patients are, this digital media and the, Google has made a revolution, so they know everything about the implant. So you should tell them when you are using the stainless steel that I'm using this. In the knee replacement also, the people are these days crazy for the gold knee, but you have to explain them what kind of implant you are using and what are alternatives available. Again, for hip arthroplasty, you know, cemented, uncemented, all those surfaces, bearing surfaces, they are different, because you have to give idea. The cost is this and the implant is like this. In arthroscopy, again, what kind of screw you are going to use, whether it's absorbable, titanium or SS. Even for immobilization material, that patient can claim later on, why you have not told me that there is some imported cast or fiber cast or something this kind. See, whatever I'm telling to you is nothing theoretical into that. I get at least 2 or 3 phone calls per day from all over India about the problems which they have landed up. And all this, my lecture has come out of that experience of the other people. And some of them are from my own experience also, because I practiced in the rural area of Fulton for 3-4 years, in suburban area, semi-rural area of Hadapsar, and then in the heart of Pune city. So I have gone through all these things. Now let the patient choose the implant and material. Give him the plus and minus points. And duration, you have to mention that partial weight bearing, non-weight bearing, that you have to specifically mention in the document you are giving to the patient. Because the patient starts early weight bearing, and if he tells that doctor मला लवकर चालायला सांगितलं म्हटल्यानंतर then you will be in problem. Then about the procedure complications. As with all procedures, you have to write this carries some risk and complications. What is the anesthesia? What is the procedure? What are alternative anesthesia you want to give? What are the complications of that anesthesia? Uh, just as a pause, when I went to Germany for in a long time for in a fellowship, I found they had a consent form of almost 4 or 5 pages, and I laughed at that because we were taking consent hardly over 4 or 5 pages. I said, why it is required for to take so much consent? But now the time has come in India that we have to also follow their two lines and have such all these things were mentioned in that consent. What are possible intraoperative complications? What are possible postoperative complications? What is the delayed infection? Also, one has to mention into that. Then there are three categories like this. One is common with a percentage of 2.5 and detail of that common. Second is less common and third is rare. Then death. We mentioned in every consent of close reduction also because this has happened in Pune itself. A patient, 28-year-old boy, having elbow dislocation and he died in the general anesthesia. Okay, which takes hardly fraction of, you can say, few seconds to reduce, but he has died in this. And if this data was not mentioned in his consent, then doctor is seriously in a trouble. So this rare complication can occur because any of the above complications you have to mention. And this also we mention every time that death can occur during anesthesia, during surgery, or even post-op period also. Sometimes our replacement or old patients, they succumb, say 3-4 days later after in post-op period, but that should also mention. And about anesthesia, as I said, short explanation of all these anesthesia and various blocks. What are the alternative anesthesia which are available? Then addition anesthesia. Sometimes you have to change from the regional block to general anesthesia, but that has to mention in the consent. Then again, name of the degree and the primary anesthetist as well as assistants also. Better always to write down the name, degree, and the registration number. The risk and the complications, as I said, as in the surgery also, here also you should mention less common, less common or rare. And again, same about the death. Now, surgical complications. These are generally common complications, unexpected excessive bleeding, fracture during any procedure, neurovascular injury, cement complications, change of plan during surgery and authorization. That if the change of plan is required, I authorize doctor to take that particular decision. In the post-operative, all of you know all these things one has to mention. Remember to mention metal allergy, which is extremely rare, but if that can occur, it should be mentioned in consent. About implant surgery, you have to mention about possibility of removal of implant in future, or sometimes, and this is additional surgery with additional expenditure, because sometimes they think everything is a package deal. You have to mention that sometimes if the after fracture is united, or if the pain during the weather or airport security, sometimes you have to remove the implant, and then complications of the implant that all of you must be taking in consent, like breakage, loosening, migration, and again allergic reactions. The abandoning surgery is another important part. Sometimes you have to abandon the surgery because any kind of reason like unexpected bleeding or unforeseen intraoperative complication, and sometimes these days because of certain problems in the hospital, the generator doesn't work, the drill doesn't work, the CM doesn't work. There are so many things into that. And one of the cases has in Mumbai itself has gone in against doctor because he was doing pedicular fixation and CM stopped working. And then he had to abandon the surgery, but the case went against him because it was not mentioned in the consent. The next is the non-medical accident during operation. Like, as I said just now, failure of the breaking down of equipments, especially arthroscopy, because you can't have an alternative for arthroscopy equipment. Then machines like Genset, OT light, OT table, suction machine, anesthesia workstation. And again, this any mishap to operating surgeon. I think last month itself, some surgeon in Hyderabad died. But he died between two surgeries, spinal surgery, not during surgery. But then that is another part which can happen, especially to the elderly persons like us. Now, further information, possibility of injury to the patient inadvertently during transfer to ward. One of the cases has come directly to me from Bangalore because he was asking all those things. The seizure was done, and while transferring patient from the operation table to the trolley, the patient fell down, was a heavy one, and she had internal bleeding and she died. And the doctors did not explain properly to the relatives, and then there was a problem in post-mortem. Everything had come up. So this also can happen. Rarely, it happens rarely, but for that particular doctor, this one rare incident can harm his life. Then possibility of keeping in the ICU with chance of increasing bills. This has to be mentioned there. Possibility of shifting to the higher centers, especially for all small nursing homes. I tell you right this at the end that you may have to be shifted to higher center in case of unexpected complication or situation. and mention that if you have any complaints about your treatment or your care, you are always encouraged to discuss them with the your surgical team. Then confirmation, this is at the end. I have read all these sentences should come into that. I understand another surgeon other than my consultant may perform the operation. They will have adequate training and supervision. I understand that I will have opportunity to discuss the details of anesthesia with anesthetic before the procedure. All these sort of disclaimer you have to take from the patient. And I understand that any procedure in addition to those described on this form will be carried out to save my life or to prevent serious harm to my health. And at the end of the consent, as I said, patient and two witnesses, and mainly, preferably first degree relatives. In the initial days of my practice, this happened. I was doing a spine surgery for a quad equina, and we had taken a signature, and that quad equina did not recover after that. And then the chaos started. I said, I have written everything on the consent that I'm going to just decompress and it may not recover. But the person who signed that was his business partner. That I did not see. So they say business partner, you have came together and you have done all these things. So all these things has to be mentioned that it has to be close relative. And if the now what we are doing is a computerized consent. It is a sort of a printed consent, but not a blanket printed consent. You can print the name of that particular patient in that, and when the consent comes out of the printer, the patient's name is there already printed. So it is patient-specific consent. So that is allowed. Then second confirmation, as I said, just few hours before surgery. Again, name of surgeon, signature, and designation, especially to the multi-specialty hospital. Now, there are other consents which you don't do. These are not medical legal consent because they come in the national registry. There are certain samples for the THR, for example. As I said initially, first all the names and everything. Then operation, total hip replacement. Then procedure in short. This is a short procedure. Then alternative procedures. What are other alternatives other than the total hip replacement? Then what are the risks? As I said, common risk 2 to 5%. Blood clots in their own language. You have tried that bleeding, pain, and the loosening or the wear. All these things, altered leg length. Many doctors have to pay huge amount in US because the leg was 1 inch smaller and shorter, and they did not mention the consent. Then joint dislocation, then less common. All this for that particular procedure you should write. Rare complication like nerve damage or altered healing, bone damage, blood vessel damage, and lastly the death. This rare complication can occur from any of the above complication, and patient can die during anesthesia, during surgery, and post-op period. And a confirmation of the consent. There's 2 times you have to do that. And lastly, the name of the surgeon. So this is the one format of the consent which I have done. Same thing or femoral nailing here. This is about the only thing is about the details of the procedure. If the patient is from Sadashbeta or the irritating patient, it's always better to do all these things. This is a big, almost operative note one has to write. And at the end, please be aware that a surgeon other than the consultant, but with adequate training or supervision, may perform the operation. So take-home message is situation has changed drastically. Anybody can get into the medical issues anytime, irrespective of his age, his reputation or experience. Can happen with anybody, as I said, even with your close friends or relatives also, your business partner, anybody. Then not to worry about what I say. Don't worry about this. Don't get scared at the beginning of the conference. Don't get stressed out. Once you accept this as a part and parcel of our profession, you become more alert and get everything known. We are studying such a complicated all procedures and everything. This takes hardly some time, but we don't pay much attention to this. Just follow everything, follow the documentation properly, and there is nothing to get worried about. Spend more time with the patient. That is important. Communication and counseling of the patient is the key to avoid medical legal litigation. Then keep all records properly. As I said, documentation and consent. And these days, now we are coming up with from the IOA to form a uniform consent all over India for a given procedure. That's what we are coming up so that in court of law, it should not happen that this has remained and this has not remained, because this is a consent which is accepted by the National Association, and that job has been given to me. So this is the take-home message. Thank you very much.
Dr. Karne sir, I have requested him to write a chapter on this thing, how to take a consent. And we are now bringing out from Maharashtra Orthopedic Association on behalf. OT is my temple book. And now he will write a very good article on this thing so that everything will be clear. And Dr. Karne sir, I request you as early as possible you finish your article.
Yes, sir, I will do that. Thank you.
Thank you, sir. I now request Our next speaker, Mr. Dr. Sangeet Gawale, sir, to please proceed towards the stage. The topic is principles and indication of intramedullary nailing.
A simple topic to begin the webinar, to begin the seminar. Indication and principles of intramedullary nailing. Over the years, nailing has been the standard treatment for long bone diaphyseal and selected metaphyseal fractures, providing sufficient stability with limited soft tissue dissection. As regards the indications, these are the areas where you can nail the fractures, the proximal humerus, the metaphyseals, the proximal femur, the distal femur, the proximal tibia, the distal tibia, apart from the diaphyseal humerus, femur, and tibia. What are you going to achieve by nailing these fractures, which are particularly at the junctional zone? These are the foremost three principles which you must follow. Restore the length of the limb, restore the weight bearing axis, avoid malrotation like this. And if you are successful, your healing will be with the callus because of the elasticity of the nail. It is always a secondary healing what you get in a nailed femur or a tibia or a humerus. The static and the dynamic interlocking nail, they have their own indications. The static interlocking is used when there is when there are severe fractures, comminuted fractures, segmental fractures like this, where you are concerned about the rotational and the longitudinal instability. So these are the indications of using that static type of nail. Whereas the dynamic one you can use whenever the fracture is stable, like a short oblique or a transverse fracture of the tibia or femur. Dynamic interlocking, one bolt only is used in the proximal and distal to get a longitudinal stability. In the dynamic hole, you use it in a elliptical slot. When the patient bears weight, it allows some longitudinal compression, and that gives better stability in these type of fractures. Whether reaming is required or not is a controversy which is going on since ages. But as regards the stability of these fractures are concerned, when you ream the medullary canal, it increases the nail bone contact. So that gives you a better stability. It allows you to use a thicker nail and your construct becomes very stable. So rim nail will have a much larger contact area it will have a better working length of the nail. The construct is more stable. It allows you to use a thicker nail so that the chances of deformation of the nail when the patient starts weight bearing are little. It, it has a high union rate and has a shorter healing time as compared to the unrimmed nail. So you can see here, this was a complex fracture and it has a thin nail has been used without reaming. So even though there is no rotation, significant rotational element, the length of the femur is achieved, but you can see the angular valgus deformity which has resulted along with the proximal deformation at the first hole. So if you just exchange it with a thicker size nail and of appropriate length, the deformity is corrected and you achieve a better stability. You ignore the comminution in the diaphysis, the fracture is going to heal in an expected time. When the nail of the same size is used as a of the reamer, uh, the amount of contact area is less, but if you increase the reaming size by 1 millimeter, the contact area increases by 38. If you increase by 2 millimeter more, so it goes on increasing like that. Reaming significantly increases the vascular perfusion of the surrounding muscles and the deep soft tissues. The effect lasts usually for 12 weeks after reaming. It also helps in internal bone grafting. It stimulates the blood flow. It activates greater cellular humoral response. It enhances the fracture healing. You can see here that has helped by a exchange dynamic nail in this case, a non-union, just a plain exchange nail wherein only distal screws were used and the fracture has healed in 4 months time. So goal of fixation with intramedullary nail is to achieve stable fixation, resulting in indirect fracture healing with callus. So these are the 6 steps which are necessary to mention. I'm mentioning this. Um, it will be discussed in the workshops also and by the individual speakers who are discussing particular fractures. The biomechanics of the nail are assumed to it is assumed to bear the most of the load initially and then gradually as the fracture consolidates the bone takes part in the load bearing. Larger diameter nails are both stiffer and stronger as compared to small diameter nails. Here is a case where presuming the fracture was in diaphysis, only one single screw was used proximally and distally to stabilize it, but in about 6 months' time, the nail broke. There is a non-union, and the screw has also broken. So that was exchanged by uh, a nail which has multiple holes distally. This has 4 holes with 4 bolts distally to give stability in the distal femur. Whenever you have a junctional fracture, the nail doesn't have a contact with the bone here. So you need to augment these junctional fractures in the distal third or the proximal third with the additional plate or using the longest available nail going in the subchondral, either using polar screws or adding multiple screws to the distal uh, fragment. Whether to use a hollow or solid nails, hollow nails are designed either in an open cross section or which are slotted or a closed section. The purpose of a slot is an intramedullary nail is to allow radial compression upon nail insertion, thereby accommodating minor bone or nail geometric mismatch. The solid circular nail, the bending rigidity is proportional to the third power and the torsional rigidity is proportional to the fourth power of the nail diameter. Whether to use a titanium or steel nail, the ultimate strength of the titanium is approximately 1.6 times that of the stainless steel, whereas its modulus of velocity is approximately half and therefore closer to the modulus of the cortical bone. if you have to address biology in certain situations where you have uh, so much of communication, so if you have achieved a good stability, like in this situation where the contact of the nail is good in both the fragments, both proximal and distals have adequate locking screws, it will go ahead. We can see even the fragment is reversed over the time just because the nail is stable. It has healed very well. The fragment which is reversed, there is no contact with the nail. You can see that has healed beautifully. Or in certain situations like this, where just addition of a cerclage wire, where close reduction is difficult, by limited opening and using a cerclage wire, whenever you're using, don't use it as a single loop, use it in a double loop that does not allow the wire to slide proximally or distally, and you can get a minimum compression required to approximate that fragment without disturbing its soft tissue attachment. And that is how it has healed. That is his range of movement. A weaker construct like this, where fragment doesn't contribute to the healing, the nail is thin, and in such situation where the contact between the nail and the bone is poor, there are higher stresses on the nail. Either it will break at the non-union site or at the screw hole site. So this is instability which is evident by a fracture subsequently. And this has to be revised by a thicker size nail with more number of screws proximally and distally, and that goes on to a healing very well. That is his range of movement. So whenever you're using nail, like how you consider the principles of uh, construct stability, similar situation is with the nail. If your construct stability is poor, that nail is not going to work. By construct stability, I mean a good contact between the nail and the bone. If you don't have that good construct, you can add a additional plate or other situations, polar screws, more number of screws, or a nail which has multiple holes, a nail which goes at the subchondral bone in the center of the distal femur and the tibia. So these are the various ways by which you can improve the construct stability in the nail as well to achieve a good union in expected time. The drawbacks in the intramedullary nail is a lack of accurate knowledge about the ideal mechanism or the mechanical environment that promotes healing. And as I said, the foremost is the construct stability in the nail also. So there are developments like, or we have to develop engineering tools in the field and more profound, which will understand the relationship between the biology and the mechanics. And if you have a choice between two, it is the mechanics which plays a significant role as far as uh, nailing is concerned in these fractures. Future prospects, uh, these are the things which are coming up where implant sensor technology can be used, where a sensor can be implanted at the fracture site in the nail, and that will give you a judgment of how much is the healing going on, and you can take a decision if it is not adequate. Surface coating technology, which is already there, uh, even either antibiotics or growth factors or BMP have been coated to enhance the healing in these difficult fractures. Even a magnet remote activated chip uh, implanted along the nail in the fracture area gives you a non-invasive information. It's a non-invasive whether there is adequate compression occurring at the fracture site to aid the assessment of the fracture healing, allow the early detection of a non-union, and to contribute to early intervention are the future prospects which are happening. And very soon we will have uh, research in this direction and useful information which we can transfer as a surgeon to our patients. So that was all about the indication and the principle of nailing. Any questions related to that, or you take it at the end? What is working length? The controversy is most of the books and everywhere that is what is mentioned. So that means if you use a 36 size nail for a comminuted fracture, for a transverse fracture, for an oblique fracture, the working length, irrespective of the fracture, will remain same. Am I right? Unlike a plate, the which will vary, which is in your hands, to whether you keep it closer to the fracture or you keep it away to get a bridge effect or to give a compression. So the same is not applicable to the nail, but all the literature, all the books describes the working length as the distance between the two screws near the fracture. But I fail to understand if your nail size is 40, 42, it will be constant for all the type of fractures. So to me, a working length is how good is the nail bone contact. See, now we have a distal third femur where the nail doesn't have any contact. It is in the center. So that is a poor construct. So you can increase the stability or improve the working length by adding polar screws, by using a nail which has 3 or 4 screws distally going through the nail, or keep the nail as close to the subchondral bone as possible. So that improves the working length indirectly of the that unstable fragment. In a in a yes, yes, both static, both static. That is what is recommended for unstable. For a stable, it doesn't make a difference. For a unstable, it has to be a long nail, static nail, whether it is a intertrochanteric, subtrochanteric, or intertrochanteric, subtrochanteric, or ipsilateral fractures. So it has to be uh, statically locked nail.
Thank you, sir. I now request our next speaker, Dr. R.M. Chandak, sir, to update us about the rimming techniques in intramedullary nailing.
Good afternoon. Intramedullary rimming is one of the most common mechanobiological technique we use in orthopedic techniques. If the medullary canal is narrow, it may be necessary to enlarge the canal. All of us would do that. And the rimming allows the insertion of a larger diameter nail, which would provide sufficient strength for our patient to mobilize early. Rimming also increases the length of contact between the nail and the endosteal surface of the bone, and that is our judgment which size nail to use in a given patient with lot of comminution. Although rimming may damage the endosteal blood flow, actually in practice, the periosteal blood flow is still sufficient for fracture healing, and during the period perioperative phase, the endosteal blood flow also improves. Before rimming, we would always like to open the canal, and that is a very important judgment in a given patient what technique you are going to open the canal, whether in tibial plateau or during the femur nailing. And the instrument used to open the canal could be most commonly used is a awl or a drill bit or a cannulated cutter. Find out what works best. To me, whether patient has an adult tough bone or elderly osteoporotic bone, on that depends your drilling entry point. So when the ends of bone are closed as in a non-union, you may have to use a drill to open the canal, as was done in this case. And when you use drilling or reaming, both actually create a hollow. But drilling is conspicuous that it draws out the material of bone, and in reaming, you don't draw out the material of bone, you are enlarging the hole. So you may have to use them judiciously. Improvising the instrument inventory for entry is really very important. And to me, the best entry owl is from the AO, which has these serrated edges, and you are able to create an entry point as well as the entry path so that your guide wire takes the path you want to take. Reaming, opening the canal and guide wire insertion is our next task. And then before that, you must evaluate the canal in toto, what way your guide wire is going to take shape. Coming to certain principles in reaming, olive tip guide wire is what usually we were starting, so that if the reamer breaks or some part breaks, you are able to drag it by back slapping. However, currently I use all separate reamers on a Caude bend guide wire. Reaming should never be done without a guide wire. Occasionally, say in tibia, if you directly insert a reamer and ream, one, it wobbles inside and you may break the reamer or may spoil the reamer. Also remember, thermal heat is generated. So after every reamer I take out, my hand would palpate the tip of the reamer, whether it has become hot. If it has become hot, run a story, talk to your person assisting you, talk to ward boys, spend some time before you take up the next step of reaming. That is very crucial because if you burn the bone, the healing is affected and people have suffered with a segmental necrotic loss as was reported in this paper. And I have seen 3 patients in my life where the whole anterior part of tibial skin around the ring segment got necrotic. Before rimming, always assess your canal and develop perception what type, what size nail you are going to use. Like in this patient, one of the surgeon failed to assess that there is a blocked canal. He kept on struggling with the rimming for a long time and had a failed nailing proposition. Evaluate the whole medullary canal before rimming is essential. All of us would do that and is what is important. Avoid hitting the medial cortex and if stuck in advancing the guide wire, so you have to need to have guide wire diverter or you can use a fossa finder. During reaming for tibia, never use the tourniquet or during that process, release the tourniquet. The guide wire can be usually central, but you can use your guide wire to your trajectory utilizing whatever principle you are using. Use tissue protector. Tissue protector also needs to be modified according to the need and moderate power and speed should be used. Use high torque, low rotational speed and incremental reaming is always better. However, you in an elderly wide canal, you can jump on 2 class also. Never drill too long in same position to prevent overrotting. What I do is, for spending this time, look at your trolley, look at something else, go to Siam and spend time. Don't rim continuously so that heat is not generated much. Guide wire centralization is crucial before rimming and a small corde bend at the tip is useful. You may have to exchange this to a straight guide wire if you want to rim till the end of the bone because on this part the guide wire can get stuck up. The correct placement of guide wire is an art and there are some specific ways you can centralize the guide wire by 3 turns and 3 half turns. Try to obtain desired guide wire position and then start reaming. The position of the reamer can be checked intermittently under X-ray control, that is CM control, and guide wire should be tapped at the end of, once you put it, just tap it with hammer that locks it into the subchondral bone. Occasionally it tries to come out. Then there is a device in the AO set which has a guide wire pusher with a black handle that you can reinsert the guide wire, tap it again so that you don't lose the traction. If guide wire is not placed centrally, this is what would happen, as was in this case, and then that required revision. Certain instrumentation which are useful. Thin rim is the commonly used from AO. There is no requirement for rimming rod exchange, and you can use it on a olive wire. But this is what my uh, suggestion is, to use a good sentinel rimmer and good striker rimmer. They are single piece. That helps you a lot, because every guide wire, every rimmer is a separate rimmer. You can have from size 5, but usually you require from size 8 up to 14. And a good power tool is what is important. This is front and side cutting rimmer. So always have one very sharp front cutting rimmer. At times the rimmer doesn't initiate rimming. So at that point you need a front cutting rimmer. So always have one very good front cutting rimmer, or you can use a side cutting and front cutting both. Power equipment is very useful. A low torque machine is not a very useful thing, and initially few low price drills gave us a lot of trouble, but if a good power drill is there, that is very useful. The flexible reamers should always be used only forward. They should not be rotated back. If you want to take out, never go reverse, because reverse may lead to uncoiling. Never do that. And then the AO flexible reamers come into various forms. Usually there are 3 shafts, and they are very useful for reaming. They may have detachable reamer heads, or we may have a common separate reamers. There are various types of reamer shafts. It could be a coiled one. It could be a nitinol. So nitinol is a very good, because it has good flexibility, and it doesn't usually damage. A coiled spring you can't rotate back. Occasionally you are stuck up, the reamer doesn't come out. The trick is push it forward again, and then at a high speed drilling speed you take it out. That way it can come out. What are the qualities of a good reamer? These are the ideal qualities, but they are not found in every reamer. So you have to mix and match your reamer inventory. So these are the various sizes available in the world, from point 0.5 mm to 18.5. In India, we very rarely require 18.5. Maximum usually is between 8 to 13 points we need. Certain reaming pearls always use the reamer rod with olive tip when you have uh, uh, separate reamer head. Cut the initial pathway with a 8.5 mm cutting reamer head. Make subsequent passes with reamer heads in zero point 0.5 increments. That's a good practice. But in a patient who has fat embolism syndrome, I would use minimum passes and use the most appropriate size you are going to use. Certain methodologies. So this is what a reamer reaming when you use. So use on a good uh, tool, and look for the reamer chatter. As soon as you get a reamer chatter, this is the time you need to hold the thigh. So don't allow the middle fragment to spin continuously. Hold, somebody should hold it, and then go on exchanging with the reamer sizes. A good rimming done for a shaft mid shaft would lead to this picture on day 8. So you do see rimming all around the fracture site. This you would not see in a non-union scenario. But in a fresh case, these rimmings are very useful. Support the thigh if you have a rimming chatter. So I would ask person to have 2 sponges in both the hands and hold and clamp to the thigh, so that the spinning does not happen. What are the effects of rimming? It is mechanical effect. The small diameter changes and enlarges. More rimming is required in non-union, exchange nailing, allograft bone harvesting, and infected non-union. There are certain contraindications to rimming as well. Polytrauma patients, we have to have minimum rimming. Open tibia fractures, it is controversial. And in presence of acute infection, you don't rim. Obviously, in tumors, you don't rim. Some complications which are really dangerous and can happen sometime in life is fat embolism syndrome. Fat embolism happens practically in every patient, but the fat embolism syndrome is conspicuous, that affects very few patients. So we have to identify those subset of patients where it can happen, and it can happen in any case, and you have to prevent further damage in those patients. In those patients, I would use a RIA reamer. These are the complications which can happen. What happens? Even a rimming rod insertion can lead to fat embolism syndrome, because it pressurizes the medullary cavity, and with the Pascal's law all around the bone. And in the experiment, when you put a tight reamer, the fat can be seen emerging out from the bone holes. So fat embolism syndrome This is what the world literature says. And if we have a ARDS, that is very disastrous. These are the common contraindication. A bleeding disorder, we will not do a rimming. Blocked canal with a metabolic bone diseases, and active metabolic metastatic disease. These are contraindications. Certain advancements or certain additional things I would do for my patients. Look at the adult femur available, femur length is only up to this point, and this much amount remains outside to connect to the bone. So for this purpose, I have specifically got a 580 mm. Manman helped me out in getting this. So what are the shortcomings of a conventional rimmer? Difficulty in rimming distally. This goes up to this point. So we can use, and then in that case, only a shorter nail could pass in a tough bone. So we can use a long rimmer. So this is what the long rimmer goes, 580 mm. Our routine length is 480 mm. So this can go up to the tip. And for going up to the tip, you don't use a quad bend, you use a straight rimmer and exchange it so that we can use. So these are certain cases where we need rimming right up to the tip of the bone. And there I would use a long rimmer, 580 mm, and then nail can reach just up convil so that you get an adequate purchase onto the bone. And this was rimmed with a long rimmer. So there are certain cases where rimming is really tough and difficult. So look at this patient. Initially, to me, looked like a pathological fracture, and it is a pathological fracture. But biopsy came negative for malignancy, and it required a lot of workup before fixation was attempted. Biopsy suggested paraproteinemia along with all tests, and then we were not able to rim this on table. So I had to use hand rimmers. So this was the patient, and this was a typical clinical presentation of the paraproteinemia. Look at this canal. There is hardly any medullary cavity. There's no, even the guide wire just could not pass even when we opened the fracture site, and that had it tough. So there, a hand rimmer is a very useful tool. The tip of a hand rimmer is more sharper than the conventional flexible rimmer. So that is where a flexible rimmer set of hand rimming is very useful, and that also was going only on one side. So tough time rimming that for almost 2 hours, and then we were able to nail that. There are certain different canals which are really difficult, like in osteopetrosis. The trick in osteopetrosis would be to use sharp multiple drill bits, use irrigation copiously, clear the flutes. So unless you clear the flute, it generates it and keeps on rotating. May use hardware drill bits, and at times we have to use abandon and select plate fixation. How to manage difficult rimming? So this is another patient where this patient had 35 years back fracture of the shaft femur, which was K-nailed at that time. The nail was removed, but now she had a second fracture after 35 years, another trauma. And look at this entry point. Here the end of the bone is totally blocked at the fracture junction. So getting this close was difficult. So we were able to pass the guide wire up to that junction, but not beyond. So had to had hand rimming again. So hand rimmers are again useful. And then with the hand rimmer, that end was, and you need to have a long hand rimmer, and then that was done. In non-union, proximal part needs more rimming. So you also need efficient rimming and widen so that the broken part can be removed. Remember, rim a properly reduced fracture. So always before rimming, take all the measures to keep the fracture longitudinally reduced, and then the reduction would be proper. Rimming also makes your nail removal easier. So if you have adequate rim plus one plus two, the nail removal at the end also is difficult. So in this clover leaf nib, this is especially important. Uh, Rimming is a boon to us for fixing the fractures adequately with good um, purchase onto the bone, and we can use a good size nail. Thank you very much. Any questions? I'll just like to. So, uh, do this practice. Take a guide. Yeah, yeah, please. So, you take a guide wire which is gently curved. Your entry point is piriformis fossa for a nail or the trochanteric medial entry, whatever you take. And then practice this, what happens. So I always like to do this. The quad bend is at the tip. So you pass the rimmer. When you pass this rimmer straight, it goes to the mid shaft and then it tucks. That is the first place where it stuck. At this point, half turn. Then you go on further. It goes to the distal third of femur. Then again half turn back It comes into the center. So try this. It is not an exact technique, but it helps you localize the uh, distal part of the nail quite easily. So usually this is 3 turn and 1/2 turn. That is how it helps in centralizing the guide wire. Of course, image is a useful thing when you want to use it.
Chandak sir, I have one query. Suppose while doing the reaming and if the patient goes into the shock and hypotension, in that situation, whether you continue doing reaming and everything, let it be with the anesthetist or you stop doing this.
So you have to identify two different situations, whether patient is going for a fat embolism and hypoxia or a patient is going for hypotension. If he is going for hypotension, that means you have done a rapid reaming, you need to do a volume replacement. If it is hypoxia which is happening, I would immediately stop in that patient, either use whatever small size nail come out or just then do a X-fix, which would be a damage control orthopedics in that situation. It did happen in one of the cases where we just started putting the guide wire and tibia and patient went into hypoxia. So we had to stop. Anesthetist tried to resuscitate. We intubated the patient, put a X-fix, came out. Patient required ventilation for a day or two. That was a massive fat embolism syndrome, but he came out after that. So this would be my strategy.
So that is very important. One is tachycardia and hypotension and hypoxia. These are the three things which have to be looked while doing the reaming. If you have a hypoxia and tachycardia, probably the patient is going for a pulmonary embolism. And if there is only tachycardia and hypotension, then probably he is going into a hypovolemic shock. So these are the two things which has to be differentiated and it should be told to the anesthetist, please inform. So that in one condition you may not require to stop this reaming, but you can do continue the procedure after completing your hypovolemia. But in a hypoxic patient, you have to stop the procedure.
Thank you, sir.
Chandak sir.
Yeah. So these are minor cases of fat embolism syndrome, not advancing to a major thing. Keep a close watch. Give them good adequate respiratory care. Always, I would do um, nebulization, uh, spirometry. Most of these patients come up. Keep a watch. Some my critical care physician advises albumin, and I have found very good result with that. So give albumin. Alba is what he prescribes. Hydrate them adequately. Don't allow them to go for dehydration, and also thromboembolism prophylaxis. If you are able to manage hypoxia daily improving, keep on that situation. Warn them that he may require assisted ventilation.
Yeah. The one of the most important sign, especially in the wards, even in the preoperative phase, is a tachypnea, respiration rate. Rather, we have made it a protocol to see the respiration rate of all the major bone fracture. We have found out the fat embolism in tibia as well as humerus also. So if that goes more than 28, patient is completely comfortable. Patient doesn't have any symptoms. But then, because we can't put the pulse oximeter to every patient in the ward, so if we, but we make a chart of this TPRPP. So if respiration was more than 20, we have found one such patient that was completely comfortable, but the respiration was 36, and then PO2 was 84, and then further. Because fat embolism is the one thing, if you detect earlier, you can treat even in your own hospital. The delay in the fat embolism, then it is a disastrous. So first thing to see in the ward is respiration rate.
Perfectly said. Absolutely very important clinical tool. Yes, Sangeet.
Do you recommend prophylactic drilling a hole in the distal canal to reduce the intramedullary pressure
So,
in those situations?
so
Four situations,
yeah,
metastatic tumor, and I think
yeah. So
does that help? Or in those who have high cholesterol, those who are obese, whom we suspect, they can go for
the,
ARDS.
the
So
unfortunate
is
thing
it
is
helpful?
when we don't suspect it happens. But fortunately, I have rear reamers, so I would use reamer irrigator aspirator reamer so that it does suction and irrigation both simultaneously.
Sunil was nodding his head. Any comments, Sunil?
You are asking the right question, Aaron.
Yeah.
I said we need to make a vent because the pressure to release that. Because if you see, you just If you see while rimming in especially closed cavity, those who want to do sometime implant removal also, after removing implant, we see once your locking bolt is we remove rim with little bit to remove the biofilm, especially the infected non-Indian patients. So that time you see the pressure, the springs out, and the material outside once you start it. So it is better to have a vent. There is a paper available there. You can see the vent there. Okay.
Yeah, one last question, sir. What is the incidence of the incidence of this fat embolism is more with either hand rimmer or a flexible rimmer?
Um, I possibly do not know the exact answer from literature. So, if somebody has the knowledge, Sangeet, you can please.
So there are two things. Your flexible reamers or hand reamers, if they are old, they are bound to increase the heat, they are bound to increase more pressure. But second, he also mentioned the force with which you are pushing it inside the canal. And third is hand reamer, because you don't know what force you are using. So it will be always more in hand reamers as compared to flexible reamers.
Can I answer that? The
Yeah,
biomechanics does not change according to newcomer or a
Is
old
he
timer.
married or unmarried?
Huh.
Is he likely to be married?
Yeah. We always use a flexible reamers because your bow is always important to have because the flexible reamers, those who are doing manually, it is extremely difficult to remove it if it is stuck and it can break. So it is not recommended to do use a unrimmed or that solid reamer because solid reamer can break inside. So always use a flexible reamer. And it is Indians are available, not necessarily you should have an imported one, but you should have a flexible reamer. And that to a pneumatic system. Those who are doing the power reamer, that is more dangerous. See, our middle ear cavities are very small and it is very expensive. Buds are very expensive. So one synthesis bud of the reamer head costs about 65,000 rupees. So we tend to use more and more and more and get, sir, I said that hitting. And hitting has offers the change and the sharpness also loses. And we can't change every 6 months. So it is better to use a proper reamer with the pneumatic system. So AO recommends with the pneumatic system, not with the power reamer. They those who go, they give attachments of reamer with the power reamer, but it is not recommended.
So go on building up the inventory is the best thing.
That's right.
Uh, the problem, see, the problem was what we have
Pneumatic
purchased
system
10
they have,
years back from Synthes is obsolete
yeah.
now, right? So they have come up with a different one, but still, any imported one is a good option. That is why I said good father-in-law is required.
Yeah,
But usually what happens is once we purchase, we tend to forget about it and we presume all are sharp, all will be helpful. Out of that, the commonest one are 9, 10, and 11. So at least these three you keep on changing, maybe 3, 4 years, depending on what volume of
that's what.
surgeries you're doing.
given a choice in TBI, it's not a big problem. In a young 25-year-old male patient, femur is a problem. So you will aim for two size big, one size big,
1.5.
1.5.
Is it different?
So it depends. I assess the canal very carefully. If the canal has more bend, you need to rim at least two more. For a PFN, I would rim even 2.5 more because PFN, if you see, a long PFN doesn't pass easily. A long femur nail pass easily, even if you are rimming 1 plus. So it depends. At least 1 plus is mandatory.
That will increase by 28% the bone contact.
Yes, that is as per the
Also
literature.
depends upon the metallurgy you are using of the nail also. More elastic the nail is, you have to get more in the range because you
Right.
need to, you are not supposed to hammer the nail. You are supposed to push the nail inside. Once you start hammering, there is a chance of fracture. So you have to get proper nail passage. So that's the reason you have to push the nail till the end, not the hammer. Okay.
So we
Sir,
welcome Dr.
sir,
Sunil
there is
to
another question. So you said that before you start the reaming, in every case you said that you release tourniquet. I want to know from the faculty, how many of you people are agreeing with him that every time you ream, you release the tourniquet? How many of you are agreeing to this point?
I do
Do,
agree.
do you release, Sunil sir?
I don't put any in tourniquet for tibia nailing anyway. We
No
never do that.
tourniquet is required.
We don't put tourniquet for
So,
tibia nailing.
so to give a mid-path answer to your question, not mandatory in every case because in case the medullary cavity is wide, you are putting a 9 nail and you hardly are required one reaming. Do it slowly, gently at a low torque, or uh, wait sometime, just pass little, then wait. The aim is only one. You don't overheat the reamer. So that is what is the crux. So if you manage with your efficiency, fine. Ideally, recommendation is to not use tourniquet during the reaming procedure. If you are, say, for example, you are using in a sickler, I would not recommend a tourniquet otherwise also. And in this patient, the reaming is very hard. So in that patient, I would release the tourniquet. And in case you require to inflate the tourniquet, tibia nailing, otherwise also there is nothing coming out much blood. So you may do it without tourniquet. So the choice is with you. If maybe it may not be.
Well, I never remove the tourniquet for the tibia nailing after reaming. I'm on the
Thank you,
other
sir.
side of the table. One important thing I want to tell you of the tip of the one tip that when you are reaming, what I do is the first initial 2 to 3 inches I ream with the hand and go up to 12 to 13. After that, once the 8 reamer is passed, we suck the femoral canal. I have got a long tip, suction tip, and we suck all the femoral canal and we go on irrigating it till the oil stops coming. You will find that if you start reaming, oil comes out of that. Even from the irrigation, oil comes out of that. The moment stops coming, then we start further reaming. So that is one of the way to reduce the fat load in the femoral medullary canal, and then the possibility of embolism, uh, irrigation, and then once fat stops, then further reaming.
Okay.
This is a course. Each and everybody is requested to clarify your doubt because probably you may get delayed by half an hour. It does not matter very much. It's not a conference. It's a question and answer and learning something. And there are very stalwart people are there. Some differences of opinion are always there. And it is a subject which is a very controversial subject and we have to try to come to a consensus. Therefore, don't be sitting. Just try to ask the question, whatever it may be. Okay, thank you very much.
Shall I start? Okay. Uh, Thank you, Aurangabad Orthopedic Association and the Guardian Minister Agashi sir for giving me this. I'm sharing this for the first time. I am working on this talk, which I am really see that we get a good delivery and where should we use this combination of nail and plate. So a lot of things have been tried. We have also tried, not necessarily everybody should agree what I am doing here on these cases. So the concept is where it is indicated, what is the stability which nail and plate gives, how it works, and is there any studies which need to do. So what nail acts as an axial stability, which usually gives a relative stability of the plate, which gives both axial and rotational slightly, which try to give most of the, we use plate for absolute stability, relative stability once a comminuted fragment. So once it is used in combination of both, will give a absolute stability. This is a new concept which Koji Kodima from Brazil has given this. It has not been studied properly, but it is coming up with the many times. So I don't want to confuse anything, but just giving this little bit experience what we have tried. In fresh fractures, if you use this judiciously, I'm using a word very judiciously. If you use this, will give excellent results. But in non-unions, this really works very well. So all these on based on this, I'm trying to give you. So what is it is useful, where it is useful, the tibial start fractures extending inside the joint, either it is proximal or distal. The femur, the mostly I use the femur, the unstable proximal fragment, which I regularly use it. Substroke fractures, I regularly use it, and any metaphaseal diaphaseal fractures, which you need to study it because the highest failures, what we have seen in many of the best of the hands, is a reverse oblique fracture and in distal femur fracture. Because nobody knows where, what is the things happen to the properly done distal femur fracture, it fails and fantastically works in non-union. So it's a super construct once you want to use it in absolute stability and may cause delayed unions in fresh fractures and non-unions works in awesome way. So again, we will go into the details. So I have one this case with 26 years male with the road traffic accident. Uh, these are his X-rays. Now, if there is a multiple fragment fractures, and everybody will agree that it is a intra-articular fracture. And see the CT scan. The CT scan will show you how the ghastly nature of the injury it is. Whatever you want to do, you cannot reduce all these fractures, all these fragments. So your intention of here is to fix with the relative stability. So for the relative stability, because you can't put a latch screws on these each and every fragment. So if you try to do anything silly, you'll get into a non-union. And this is the 2D picture, how the void has created. So how to treat this is to have now the distal femur fractures, we have shifted from one implant to two implants. That means a combo, maybe a nail plus nail, with a nail with a small ender nail, a big nail with a big plate, a big nail or a small plate, lots of combinations. Whichever the combination works well, we have to come out with the study. And that is the way I be treating these kind of fractures, whether to on the medial side. This is these two small 10 titanium elastic nails will give you elastic fixation on the medial side, which we propose that it always prevents the collapse. The commonest cause of non-union and distal femur is a medial void and a medial collapse. So you need to do a buttress, something on the medial side. So some people are doing a plating, some people are doing a nailing plus plate, some people are doing the intramedullary DFN, and then they'll lock it and put a plate outside. I have also started doing that, but we are in evolved position. But by far, in such fractures, this method has helped us very well. So it is solidly united, and that's the reason I was talking about when the morning there was a case Dr. Chandak showed of the implant removal. The distal femur is united here, but if you see the anterior void, which is given by the fracture geometry, the gravity has pulled down all the fragments, and that is the reason the fracture has united, but there is a void. If I remove this implant, this patient may land up in a fracture. So this implant, till we put a graft or something to reconstruct that anterior cortex, we will not be able to remove the implant. So it is completely solidly united, and this is a function, the patient gets it. Now this comes to this, a simple looking fracture. Uh, then this is a CT scan of the fracture, and there is a fracture there in the Hoffa on the medial side. So this combination of a nail and the buttress plate on the medial side, which works very well because the buttress plate is a very small plate, not that giving a big stability on the, it's the buttress plate. So it is not a giving some sort of absolute stability. So you must realize and read your thinking invention that what is to be done, where exactly, and how the principles work. Principles does not change. Any intra-articular fracture needs absolute stability, and which plates acts at, and the short femur give you a relative stability. So works on very well. Now coming to the subtrochanteric fracture, this is one of the most troublesome fracture to the orthopedic world. Everywhere, worldwide, there are many things. Many people have tried plate, the angle plate, the locking plate, the newer femoral plate, the long PFN. Everybody has shown lots of, about 28% of the failure rates worldwide. The best of the implants and the best of the surgeons have shown this. Because once we get the CT scan of all, this will show you the all column fractures. So all column fractures with one implant, which is not enough to tackle. That's the reason the alone plate, alone nail will not give you enough stability till that the fracture heals. So once this is done, especially in younger patients, you need to give some additional, because once it is failed, it is the onus will come on the surgeon, not on the patient. If the patient has come to a faith that you will do a better job. So once you do this, so we fix this with the multi-column fracture with the plate, and this plate is anterior. Remember, this is the anterior bridge plate, which prevents your, so it will not give you absolute stability, but it is called a absolute stability, and that it gives a superb union of around callus formation. So once it is absolute, you don't see a callus. Once you see the abundance of callus, and this way the fracture unites, and patient has sent, because of the corona he did not come, so he sent me the photograph, what I wanted. So he has got full functional working. Now coming back to the tibia, the compound tibia fractures and the high velocity fractures injury comes with this. So we have to treat these intra-articular fractures. Then coming with the, he came with this external fixator on, treated by somebody else with the debridement and fixation. And then this was after getting this proximal tibial fracture, and there is a short femur fracture. We could have used now the long plates as a absolute stability, but nowadays we started shifting this to a plate and a nail combination, which gives you a support on all along the global fracture fixation, and so that the patient will have a reasonably good movement. And he has also sent the pictures from his home, so it gives a better result in stability point of view. But you must understand where you want to put a plate and where do you want to put a nail. So this is the case again, a small similar patient with the distal femur, distal proximal tibia and a plate and nail combination. Now coming back to the distal tibia, again the distal tibia in osteoporotic bones, especially the ladies, you get a cracking of the, where while doing also nailing, you may get a secondary fracture. So in that, so this is a case with the, see the void. I have CT scan here, and actually I forgot to put a 2D CT will tell you the void, the big void there. So alone nail will not be a good, so that you can pass a small buttress plate on the medial side, a small buttress plate, which will give you a better result and a stability. You don't have to open it, just to take small stab incisions and pass this locking buttress plate, and it gives excellent healing. Now the coming the role of this combination, especially in the non-Indians. So non-Indians, this is a real boon for all. So those who have got a lot of non-Indians, they can start using this, because that requires absolute stability. This is the case, our case only. So one of my lecturers did this. This is the way we should. The mistake to me is he has used a short nail, and we done what we have started doing this a buttress plate and nail combo. Still, it has failed and broken. So non-Indian is very common. Or that's the reason I have stopped using the short PFN, because reverse obliques will give you a lot of pain, and the patient will come up with the breaking of the implant. So I use this a long PFN and the long plate. If you see this is a combination of plates. So this is a percutaneous way of doing it, and you see the stability. There is nothing disturbed down there, only one screw on the down, and the plate is long enough to give you excellent union, excellent stability, and excellent fixation and excellent function after that. So that, but absolutely, you have to be very careful in choosing these implants, which you require to have a proper training and proper use of your principles wherever you want to use. This is an infected non-Indian. Again, a ghastly type of get. Still, we get a K nail in that, and infection, and we treat with the antibiotic coated nail with Elizaro on, so that you give rotational stability, and the intramedullary infection is taken care by the antibiotic coated nail. And once this is nail we removed, and then we put this combination of a plate, a small plate, and the long nail, which works very well in absolute stability. Though there is still infection, but the fracture has started showing excellent union. And eventually the fracture has united well and is a good function. Patient is sending the photograph from his house so that he can do it. Another common way of doing it is the plate, small plate bending into a virus. It broke, and then we use this osteotomy and fix the nail with the plate down and upstairs. So gives a absolute stability on this, and then eventually the fracture is united in the downstairs. Now the coming problem is with the fresh fractures. If you try to impose the same principle on the fresh fractures, then you have a lots of problems. The real problems comes here. This is a patient. I would have used the olden way of my doing it, the locking plate on the lateral side and the medial ender snail. But Dr. Dinadayalan from Ganga Hospital has started doing the intramedullary nail and the plate combination. So we shifted to this kind of fixation. This is a CT scan of that same patient, which is a intra-articular fracture. So we treated with this a nail and the plate. Okay, this looks good. Patient starts walking next day. It's very stable. And still the 6 months, there is no callus. This is after 8 months. Still there is a small callus. The patient has no pain. Patient is coming, but on X-rays it is showing less callus. So why it is so? Because it is a super construct now. It has stopped. There is no activity at all at the fracture site. So the fracture requires some sort of axial mobility, micromotion, and especially the comminuted fragments where you require really a relative stability rather than an absolute stability. So we want to try this because we have burnt our fingers. With the ender nail also, we have plate, nail. So all these combinations have not been. So one of our students has done these cases. He has given a small nail and a long plate. So that works very well. So nail is functioning as an axial and the plate is so it gives a combo of principles. But this is really a very absolute because the plate through the locking bolt going through the nail also. So that gives there is no micromotion at all. So sometimes I am fear that it may fail. So that is the reason you should be very careful in choosing this kind of fracture. Another patient with the floating knee, we tried, this is CT scan. We could have treated with the just DFN, but we treated this because we thought that the stability is not enough. Still showing the patient has no pain, but even after 6 months, there is no callus form. So that means the stability is more, but the biology is not functioning properly. So eventually, so we have to be very careful this kind of combination using for a fresh fracture. So for conclusion, so fresh fractures, nail plate, absolute two may be a still controversial. I can't say just treating 4 or 5 patients, I cannot just change my opinion or I cannot impose any opinion. But definitely a small nail and the big plate has given good results everywhere. A big nail plus small plate, which also works very well in all metaphyseal areas. A big lock nail and a big plate becomes very rigid and almost like a super construct, so that it is extremely difficult for the patients to get showing some sort of callus, because we are also happy to see the callus there. It is not that it may not be a non-union, maybe a delayed union, but it will heal. That is the reason, because everything is MIPO, there is nothing is disturbed, but still there is no micromotion happening at the comminuted fracture site, and that is the reason we should be very careful while doing this in a fresh fracture. But for the non-Indians, it is really, really working very well. So whatever this combination is there. So take-home message is a metatarsal fracture femur, a proximal femur is the big nail, the long nail, and a small plate. For distal femur, a big plate and a small nail or an unlocked nail. I would say unlock. Those who want to still use a DFN, they can use a small nail with no locking. So don't lock at the proximal proximal end. Just let it be there so that whatever the axial stability is given, but the plate will take care of the, so both combo will help you in an absolute way. So tibia for both proximal and distal, a big nail and a small plate. And non-Indians, it's a big plate and a big nail, maybe a good answer for a absolute stability. I thank you for, and I request all to register for this MOACon 22 in Goa. There will be Taj convention. There will be a workshops, and there will be a lot of newer things in MOACon this year. So I request everybody to register. Thank you
Thank you,
very
sir.
much.
Sir,
Any
sir,
questions?
sir, one question. Sir, excellent presentation. Thank you. Congratulations. Sir, what is the logic? Because both the sides are metaphyseal, like proximal femur and distal femoral. So, what is the logic that in proximal femur you put a small plate and a big nail, and in the distal a small nail and a very big plate? Because the plate goes from distal to proximal, like I mean,
Correct.
yeah.
Correct. So that was the contention that to give, both have failed in many times. In many of the times, both have failed. But our success rate with the nail in the proximal femur is very good, and distal it is not good. So we have tried ender nail on the medial side, medial plating, then intramedullary nail, nail plus plate, dual plate, everything. So that's what I am very much scared, and now I don't want to recommend the long plate on the distal femur, from distal femur, and a long nail. I would use a small nail to give axial and a long plate which go up to the lesser trochanter. That is my ease. But so I don't recommend a distal femur, a bigger plate and a bigger nail. With those who have seen 2-3 cases, but still they are under experimental. So I don't want to impose anything. I just wanted to have a combination.
Sir,
And
those
why it works very well on the proximal femur, because the rotational stable nail in the Cyrus nail or a PFN, long PFN, gives excellent results on the medial side. So medial varus collapse is to be prevented, and the lateral wall reconstruction is done by the plate. So nail and a small plate works very well everywhere. That's what our contention. Yeah.
Can I add, Dr. Gade? See, distal femur has a metaphysis. Proximal femur has a cortical bone which takes a longer time to heal. Right? Now, the principle would be different. What he's trying to say is the principle is compression when you're using a more stable fixation in the proximal femur. So that means you require a smaller plate. Distal femur, you require little elasticity. So a bridge plate in that is why a long plate, right? And nail, as he say, the short nail is what is required. But if you do the exactly opposite, so there proximally there will be too much of elasticity and distally too much of rigidity, which is not required. That is why he is recommending that.
Sir, when we are putting a
Am
distal,
I right, Sunil?
Yeah, absolutely, absolutely.
so when we are putting a distal femoral nail along with the plate, should we aim that the screw from the plate should pass and act go to the static or dynamic this thing, whether that will increase the biomechanical stability?
That is the crux, that you should not do that. That will give you more rigidity. That's what I'm saying. That from the plate, nail distal locking bolt, I mean proximal locking, and then that pass through, it is not recommended. So don't do it.
in that case, you mean to justify that the intramedullary unlock nail is just to prevent the medial collapse?
No, no, no. The axial support, the midline support is required. Why alone plate fails? Because of the varus collapse. Okay. So either you have to put something on the medial side or in a central side.
The plate is as it is going to hold the fracture very rigidly.
So
So
it
unlock
will not.
nail in a transverse fracture and unlock nail in a communicated or maybe a oblique fracture. The two geometries would be absolutely different
But,
situations.
but it has failed. The alone plate, best of the plates have failed. because of the even in spite of median, there is no void. Still, there is a failure. There is a varus collapse. So nowadays, so it is now world going towards the dual implant. So dual implant may be anything. That intramedullary nail and the plate, or what I have used it indoors nail on the medial side, which has worked very well, very well. I have done almost now 90 cases of distal femur, comminuted distal femur, which we already sent for publication. There will be a multicentric study also on Dr. Solapur, Dr. Everybody is doing it now. From Chandigarh also we have cases. So the multicentric study is showing the distal plate and the medullary, the tense nails gives excellent results on the medial side. But Dr. Dina Dayalan just showed me they have started doing interval nailing for the distal femur and the plate. Same thing he is also doing the nail for the proximal femur and the locking plate. They have reversed it. They have used the nail, unlock nail. There is no lock in the proximal femur. And the proximal femur plate they have put uh, like that. So how it works, I don't know. Okay?
Thank you, sir. I now like to invite our next speaker, Professor and Head Dr. M.B. Lingayat, sir. The topic is nailing in segmental fractures.
जी
करून ठेवा तुमचं प्रेझेंटेशन डॉक्टर गाडेकर.
Good afternoon, everyone.
Good afternoon, everyone. After storming session on rimming, non-rimming, how to nail the long bones, I have given a topic to give a tips and tricks of reduction, nailing, and rimming. So I try to explain it in the smaller way. You all know that the segmental fractures are challenging for most of the surgeons.
most of the surgeons, they have a difficulty in reduction and giving a good result. They are known for many complications such as severe soft tissue damage, compartment syndrome, delayed union, non-union, varus and valgus malalignment. Before starting the tips of the reductions, before that I give some clues for reduction of the in the segmental fractures. First is the position. You all know that positions are different for the femur and different for the tibia, and positions depend upon the preference and the experience of the surgeons. In the figure, they show that the position for the tibia, some may use the position and hanging at the edge of the table or bending the knee more than 90 degree on the table. So our practice, we keep the leg by the side of the table and bend around, approximately around 100 degree. This is the position for the femur. Most of us are doing the femur in the practice table or in a lateral position. Our practice is to do the femur nailing in the lateral position. Approaches, you all know that for the tibia, approaches are medial, palpebral or central. Nowadays, our MOA president developed separate approach, that is suprapatellar nailing for the tibial fractures. Entry point is very crucial for the tibia as well as the femur. You know that depending upon the level of the fractures, for example, if the tibial fracture at the level of the middle third, lower third, your entry should be in the center area. If the segmental fracture in the tibia, it is in the upper third, so your entry should be slightly lateral and slightly higher. Opening the medullary cavity is another trick. Your femur should be perpendicular to the plateau of the tibia so that you can't do any malalignment at the fracture site, typically in the proximal one third of the tibia. Guide wire insertion is another technique which is useful to get a good reduction in the segmental fractures. The figure itself explains that how to put a guide wire. For example, in the tibia, if you are dealing with the segmental fracture, which is including the upper one third of the tibia, so your entry should be